in hearings and the hearing dates that they were heard. Thank you. No, I'm fine. We're going to transition now to Part C of the agenda. Again, earlier we went through all of our vote-only actions. I got them, yeah. With the exception of 2. And so moving on to page 2 of 23 of Part C agenda, we will hear first from the Department of Managed Care. We've had a staff transition here as well as at the table.
Tell me when you're ready to start. Okay. I just said good morning to somebody, which shows you kind of how my day's gone. Is it tomorrow morning yet?
It might be. Somewhere in the world it is.
Anyway, so good afternoon. Shelley Roulard, Director of the Department of Managed Healthcare. We have 2 spring finance letters before you. The first one for SB 964, which relates to network adequacy and timely access. SB 964 requires the department to annually review and assess all full service and behavioral health plan networks and standardize health plan reporting of compliance with the timely access standards. Our spring finance letter requests 25 permanent positions to address workload. Of those, 23 are in our Office of Plan Licensing, which will do the actual plan network reviews and developing the timely access standards, and then 2 positions at the Help Center in the Division of Plan Surveys to oversee enrollee grievances and network adequacy requirements. The proposal also includes $230,000 for fiscal year 2015-16 and ongoing for statistical consulting and services to interpret data, develop standards, and determine network trends. So to develop this proposal, the department conducted a workload analysis based upon our experience in conducting network reviews prior to the passage of 964, and using information we had on how many unique networks currently are offered in California. There's a total of 45 health plans in California that are subject to annual network reviews under SB 964. Each plan has up to 5 different types of providers that SB 964 requires the department to review separately. Primary care providers, specialty care physicians, hospitals, mental health providers, and ancillary providers, which includes pharmacy, home health, pediatric, dental, and vision. In addition, there are 4 unique types of product networks, being HMO, PPO, EPO, and Medi-Cal. The department must evaluate each health plan individually by network type and by product in all 58 counties. So what this ends up being is about 5,000 new annual network reviews. Prior to 964, the department reviewed approximately 500 networks, but not on a regular basis because we were just reviewed them in limited circumstances, such as when there was a service area expansion or a new plan coming onto the market. In addition to the annual network reviews, the department must also perform a review of each of the 45 health plans' timely access compliance reports, policies, and procedures. So you had asked for an update on our implementation of SB 964 so far. So the bill authorized the department to develop standardized methodologies to measure health plan compliance with the timely access standards. After extensive stakeholder input, the department finalized the standard methodologies for measurement year 2015. This will be reported to the department in March of next year of 2016. The standardized methodology for measurement year 2015 includes 2 different options for plans related to a standardized provider appointment availability. One is a survey methodology and the other is an audit methodology. Our goal is to move plans away from the survey methodology to an audit methodology for measurement year 2016. For measurement year 2014, which the plans recently submitted their data, all full service and behavioral health plans submitted their data as of March 31st. That data has been received and our IT division is currently running exception reports of it. The reports will identify any potential discrepancies for the plan to address. And then once that process is complete, our Office of Plan Licensing will perform the network adequacy reviews. Only 4 plans didn't submit their data by March 31st, and so on April 2nd, we notified the delinquent plans that their reports were immediately due, And on April 6th, we sent letters of admonishment to the plans that still hadn't submitted their data. But as of today, all those plans have submitted their reports, they're being analyzed, and we're getting to work on them. The committee also asked how the department is working with stakeholders to implement SB 964. The department hosted 4 stakeholder meetings to discuss the standardized methodology for timely access reporting for measurement year 2015. We had 3 in January, 1 each with plans, providers, and consumer advocates, and then another combined meeting in February. Following these meetings, the department shared draft versions of the survey and standardized provider audit methodology. We solicited feedback from stakeholders on the draft documents and incorporated those suggestions into the finalized methodologies that are on our website for measurement year 2015. Going forward, we plan to engage stakeholders, including ledge staff again this summer, to work on improvements to the standard methodology for measurement year 2016. So that's the proposal. I'm happy to answer any questions you may have.
Finance? Let's open it up for public comment. Which one is it coming up for?
Beth Capel on behalf of Health Access California. As the members of this committee know, we were the organizational sponsors of SB 964. We are pleased to have been consulted by the department in its implementation. However, the budget request that is before you today is fairly substantial and is certainly a more substantial budget request than we had envisioned when we initially sponsored the legislation. We are not opposed to it today, but we would suggest that the committee would be advised, well, we would appreciate it if the committee would ask for a report back next year. And part of what gives us concern is the basis of the workload assumes that every health plan has a different network for Medi-Cal and a different network for the individual market than the group market. Yet, for example, Kaiser Permanente uses a single network for all of its business, and we hope the department will not find that Kaiser treats Medi-Cal enrollees differently than they treat other enrollees, that instead they treat them the same. We know they are looking at this and asking this question. Similarly, our county organized health systems and local initiatives have a single network and do not have different networks for different products. This was Anthem and Blue Shield and a number of other commercial plans that had different networks for different products. We are working with them. We are not opposing or opposing the proposal today. We have always supported the department in having the resources it needed to implement the bills we sponsored, but we would ask that the committee relook at this again next year to be sure that in fact this was what was necessary and just to get a report back on it. Thank you.
Thank you. Next witness.
Linda Way with Western Center on Law and Poverty. We were in support of SB 964 and its implementation. And so, like our colleagues at Health Access, would look forward to additional data, but are in support of the implementation of this bill.
Thank you. You ladies holding up the wall? Okay. We don't want to fall. Yeah, I don't want you to fall either. Thank you very much. If you turn to page 11 of the agenda, you'll see the staff recommendation is to approve this proposal as the more systematic and organized review of health plan networks as required by SB 964. And that's out with a 2-0 vote.
Thank you.
Thank you. Moving on to item 2, the health premium rate review federal grant and budget bill language.
This spring finance letter requests federal spending authority of $589,000 for fiscal year 2015-16. The department was awarded a grant in that amount in the cycle 4 of the federal health insurance rate review program and in support of the Affordable Care Act and conforming state legislation, SB 1163, passed in 2010. The grant term is from December 19th, 2014 through September 18th, 2016. $194,500 of the grant funds will be used for actuarial consulting services and $395,000 for an IT consulting contract to enhance the IT infrastructure of the department's premium rate review program. The department anticipates the IT contract will be completed by April 30th, 2016, and the actuarial services contract will go through the term of the grant through September 18th of 2016. All funds will be encumbered in the fiscal year 2015-16. I also want to mention that the department is working closely with Caltech on its review of our draft feasibility study report, which appears to be nearing completion. We're confident we will have Caltech's approval prior to the enactment of the budget. With that, I'd be happy to answer questions.
Excellent. Ramani, anything? LAO?
Thank you, Madam Chair. Senator Monning, Felix Su with the LAO. We just wanted to make a quick comment about the recommendation for the modified budget bill language. We understand that there is strong interest in seeing the objectives of this project and the federal grants associated with this expended and completed on time. However, we do want to point out that the modified budget bill language could create some degree of project risk. The intent of Caltech's review is to ensure that the project is best positioned for success, and should DMHC move forward without Caltech's approval, as suggested by the budget bill language, the project may be prone to more issues down the road. Thank you.
Thank you very much. Finance?
Thank you, Madam. Thank you, Madam Chair. Guadalupe Manriquez with the Department of Finance. We would like to note that the recommended modifications to the budget bill language may not be necessary given the schedule of the review process of the feasibility study report. As the director mentioned, it is anticipated that the review process will be completed by June 30th of 2016. Thank you.
Thank you. Public comment.
Good evening, Madam Chair and Member. Tam Ma with Health Access California. We support the staff recommendation to approve this item. Health Access sponsored the underlying legislation to implement rate review in California, and it has saved consumers over $400 million. The additional expenditure authority will allow the department to improve the rate review program and improve transparency in health premium rates. Thank you.
Thank you very much. Senator Monning, I would welcome a motion to approve the modified budget bill language. I appreciate Finance doesn't think we'll need it, but we, have had experience missing deadlines, so I think that we should go ahead and approve this modified language. So moved. Again, the language is specified for members of the public on page 20 of the agenda, and that'll carry with a 2-0 recommendation.
Thank you.
Okay, thank you very much. We'll be transitioning to Mr. Martin, who's going to present all of the health-related proposals for investment, starting on page 14 of the agenda.
Madam Chair, if it's okay with you, I'm going to have Felix here from our office do the first 10, and I'll do the last 18.
Come
He'll
on,
cover
I know you
DHCS,
could. Mr. Martin, I have so much faith in you. I know you could handle them all.
I could try.
But that's fine, not a problem. Just, again, for the public, they'll be presenting all of the health-related proposals that were submitted by advocates and others. Again, the previously heard restoration issues won't be heard again, just like in human services. They can be found on page 23 of the agenda. If we've heard them before, we'll not hear them again. These are brand new proposals that were brought forward that have not been heard yet in committee. And again, we will take public comment at the end of all the proposals being provided. Thank you very much. Let's get started, gentlemen.
Thank you, Madam Chair. So I will be going through the proposals related to Medi-Cal in the order listed in the agenda, and where noted in the agenda, I will also provide the estimated annual general fund cost. Proposal number 1 would restore optional Medi-Cal benefits that were eliminated in the 2009 budget for an annual cost of $108 million. Proposal 2 would provide pediatric day health centers with a 5% rate increase for an unknown cost. Proposal 3 would increase funding for data monitoring and tracking of children's access to care in Medi-Cal to address identified access shortcomings and to enroll uninsured children eligible for Medi-Cal, particularly children of color. Proposal 4 would limit estate recovery in the Medi-Cal program to only those healthcare services that are required to be collected under federal law, would require the usage of a narrow definition of estate in federal Medicaid law and would allow a hardship exemption from estate recovery for a home of modest value for an estimated annual cost of $27.4 million. Proposal 5 would revise the Medi-Cal and Family Pact reimbursement formula for drugs and supplies dispensed by specified clinics by requiring the clinic dispensing fee to be the difference between the actual acquisition cost and the Medi-Cal reimbursement rate, and would also remove the maximum dispensing fee caps in existing law for an estimated annual cost of $6 million. Proposal 6 would increase the amount of income that is disregarded for the purposes of calculating eligibility for the Medi-Cal Aged and Disabled program, with the resulting income standard rising from 123% of the federal poverty level to 138% for an estimated cost of $30 million annually. Proposal 7 would provide an increase in the personal needs allowance for persons residing in a nursing home from $35 to $80 a month for an annual cost of $13.4 million. Proposal 8 would provide a rate increase for the AIDS Medi-Cal waiver program at $4.8 million annually. Proposal 9 would provide funding to the program of all-inclusive care for the elderly, or PACE, to address geographic rate differences in facilities in Southern and Northern California at $4.4 million annually. And Proposal 10 would extend eligibility for full-scope Medi-Cal to individuals who are otherwise eligible but for their immigration status. It would also require the state to pursue or seek a federal waiver to allow persons to obtain coverage to cover California who are otherwise not able to because of their immigration status. And in the event that the federal waiver is not approved, would establish a state exchange for these individuals to obtain coverage. The annual cost is unknown, but likely in the range of hundreds of millions annually.
Proposal 11 would provide funding to sustain the Robert F. Kennedy Farm Workers Medical Plan at $2.5 million. Proposal 12 would provide funding for the California Resource Centers, Caregiver Resource Centers, which are community-based centers that offer services to families designed to assist unpaid family caregivers of adults with chronic disabling health conditions. It's estimated at $7.6 million. Number 13, this proposal would restore funding for the Dental Disease Prevention Program. From 1980 to 2009, this program provided school-based oral health prevention services to approximately 300,000 low-income school children in 32 counties. The estimated cost is $3.2 million. Proposal 14 would restore funding for teen pregnancy prevention efforts at $10 million. Proposal 15 would increase funding to local health jurisdictions to address sexually transmitted disease screening, testing, and diagnosis, and to support outreach and education for $10 million. Proposal 16 would establish a grant program for local agencies and community-based organizations in order to reduce the rate of fatal drug overdose caused by prescription analgesics and other drugs at a cost of $2 million. Proposal 17 would provide funding for pre-exposure prophylaxis access and affordability program. This would include outreach and education, patient navigation, clinical and non-clinical provider training, and cost-sharing assistance for uninsured and underinsured individuals at a cost of $3 million. Proposal 18 would provide $2 million to increase staff, enrollment workers, and $1 million to implement program improvements in the AIDS Drug Assistance Program, Office of AIDS Health Insurance Premium Payment, and Stability Funding. Proposal number 19, this proposal would provide funding to support high-impact HIV services in small and mid-sized counties at a cost of $3 million. Proposal 20 would provide funding for syringe exchange and disposal programs by creating a state clearinghouse in order to purchase sharps disposals, containers, sterile syringes, and other materials vital to the operation of these programs at a cost of $3 million. Proposal 21 would provide funding to purchase rapid hepatitis C antibody test kits. With the requested amount, it's estimated that approximately 33,333 kits could be provided to community-based programs that serve low-income communities at a cost of $600,000. Proposal 22 would provide funding to support at least three-year demonstration projects to include innovative outreach, screening, and linkage to and retention and care efforts for people with HCV at a cost of $5 million. Proposal 23 would provide funding for 3 years to fund the California Parkinson's Disease Registry to support competitive grants, contracts to research institutes, universities, and nonprofit organizations to implement and maintain a comprehensive Parkinson's Disease Registry, $3.7 million cost. Proposal number 24, this would provide funds to support the addition of Federal Centers for Disease Control and Prevention's caregiver module in the annual Behavioral Risk Factor Surveillance System survey at a cost of $70,000. Proposal number 25 would provide funding to the Adolescents Family Life Program. The social health, educational, and economic consequences of adolescents' pregnancy would address these by comprehensive case management services to pregnant and parenting teens and their children at a cost of $7.8 million. Proposal 26 would provide funding to establish an autism surveillance and public health information program that will link Department of Developmental Services records, vital statistics records, and other existing data in order to track the number of children with autism in the state. And that's at a cost of $500,000. Proposal number 27 would provide increased appropriation of $8 million from the California Health Data Planning Fund for the Song Brown program in order to provide ongoing support for existing residency slots. And then proposal 28, I understand there's a correction on this. The City of Carson requests $50,000 to support its Joseph B. Jr. and Mary Ann O'Neill Stroke Center. The it says $500,000 in the agenda, but I understand the correction is $50,000. Oh. And that concludes the presentation of the proposals.
Thank you very much. Senator Monning was about to make a proposal to accept all of the recommendations, but then all of a sudden his mic just broke. So I think the ladies from finance must have unplugged it from underneath. Thank you very much, Eliel, for presenting all those. Appreciate it. We'll open it up to members. Oh, I'm sorry. Finance.
They're going to accept it.
Yes, right.
Madam Chair, Senator Monning, Mayor Kasekan from the Department of Finance. This is the first time we're hearing some of these proposals, and they're not part of the governor's spending plan, so we can't support them at this time.
Understandable. Thank you very much. This is the first time they've been heard in the subcommittee, but that's why we have proposals for investment that have been brought to us by advocates so they can be heard and a part of the official record. We're going to open it up to public testimony. I just want to acknowledge that we received several hundred postcards supporting budget item 4265, the restoration of AFLP. I was going to see if I was going to read something, but I just wanted, for the record, we received them. Thank you very much for all the effort put into collecting information from AFLP participants from across the state. Thank you. First witness, and we're going to ask everyone to keep it within 2 minutes, please.
My name is Mark Siegel. I have Parkinson's disease, and I'm here as an advocate for the item 23, which I'm really gratified to hear the support. Parkinson's is a deadly disease. People die from it, but it's more like your life fades away. You unwind, you lose control of your muscles, you lose your sense of smell, voice, and legs. I fall 7 or 8 times a day, and the thing is that nobody knows how many people have Parkinson's. Nobody knows whether young onset, younger than 55, is increasing. I was 47 when I was diagnosed. That's too young for Parkinson's. Nobody knows if you're more likely to get it in the city or in an agricultural community, or if you're Jewish or if you're African American, or so there's only one way to find out, and that's really to count them, and that's what we're proposing to do. This is based on a law that we passed in 2004. Shortness of breath is another symptom, and this bill created the PD registry, California PD registry, but then it was right at the peak of the state's budget problems, and we agreed to pass the policy bill and not take money from the state. We got some money from Michael J. Fox and from the NEIH and the Department of Defense, and ran it for 2 years, 3 years. Now we're looking to infuse it with some fresh money. We got the new era of electronic records, which will make data collection easier and less expensive. And so I think I just urge you to vote for the Parkinson's Registry. Thank you.
Thank you very much for your testimony. Appreciate you sticking with us for this long hearing today. Thank you. Next witness, please. 2 minutes.
Yes, ma'am. Beth Capel with Health Access California to speak to the proposal on expanding coverage for the remaining uninsured. As this committee heard recently, as a result of the president's action, the number of people who would be eligible for Medi-Cal as a result of existing California law would cut in half the cost of this program. Senate Appropriations heard this item on Monday. The current estimate is, after you take into account the effect of the president's action, that the cost of this for the Medi-Cal piece would be around $100 million to $300 million. We understand that's still a significant amount, but very substantially reduced from the amount in prior years. And we believe that enrollment would be somewhat slow. After all, these are undocumented persons, even if we are giving them full scope Medi-Cal. So with that, I will leave other items to my colleague.
Thank you very much. Next witness.
Linda Way with Western Center on Law and Poverty. We support restoring all optional benefits, but specifically note the need for full restoration of adult dental services. Our legal aid advocates point out that people are still being asked to pull their teeth or delay needed medical treatment. In one case, a cancer patient had to wait 10 months to begin chemotherapy because the oncologist would not clear chemo until restored adult dental benefits were provided. Related to Medi-Cal estate recovery, we thank the subcommittee for considering limiting estate recovery to what is federally required. This is a critical equity issue, as only the poorest Californians, those on Medi-Cal, are subject to estate recovery. We've heard from many low-income consumers that this remains to be an enrollment barrier to Medi-Cal, most of whom would rather forego health insurance rather than risk losing their modest homes. We're working with the administration, but question the $27.4 million general fund estimate provided by DHCS, as we believe the fiscal to be lower and can provide some data to support that. In relation to increasing the Medi-Cal aged and disabled program level to 138%, we thank the subcommittee for considering this, as it provides parity and relief for low-income seniors who, but for their age, would qualify for free Medi-Cal. Under healthcare reform, all seniors, all adults with incomes up to 138% of the FPL are eligible for free Medi-Cal, except for seniors, so we urge this measure be made a priority. And finally, we'd like to echo the sentiments of Health Access in relation to expanding Medi-Cal to cover remaining uninsured, regardless of immigration strategy, as this proposal picks up where healthcare reform left off, and so we strongly urge the support of this.
Thank you. Next witness, 2 minutes, please.
Good evening. Tam Ma with Health Access California. We dittoed Western Center on Law and Poverty on restoring the so-called optional benefits that are non-federally mandated but critical benefits that were eliminated for budgetary and not policy reasons. We also support full restoration of adult dental and Medi-Cal. And with regard to estate recovery, just want to point out that it's particularly punitive here in California because of our reliance on managed care, and that literally for every month a consumer over age 55 is enrolled in Medi-Cal managed care, the full value of the Medi-Cal managed care capitation payment is a lien on the estate. And right now it's an average of about $600 per month, regardless of whether the consumer gets care or not. And we want to see the estate recovery policy, be limited to just long-term services and supports, which is what's consistent with the minimal federal requirements. We also support increasing the Medi-Cal age and disabled program level to 138% of the federal poverty level. And finally, we support the request in ADAP's OAHIP stability funding to get funds to pay for additional ADAP enrollment workers. We believe this investment will help the program better serve low-income people living with HIV. Thank you.
Thank you. Next witness.
Kimberly Chen with the California Pan-Ethnic Health Network. We're here in support of the expansion of Medi-Cal to cover the remaining underserved regardless of immigration status. As we know, it's far more cost-effective and better for folks to receive preventative care than receive their care through emergency rooms, and this bill would go a long way in doing that. So we urge your support of that.
Thank you. Next witness.
Madam Chair and members, Rick Rollins here on behalf of the sponsor of item 26 on your agenda, the Autism Surveillance and Reporting, which is Ms. Jill Escher and the Autism Society of San Francisco, also with Marty Omoto and the CD-CAN and the Association of Regional Center Agencies. 18 years ago, I came to the legislature and asked then Chairman Mike Thompson to put some language in the budget as budget bill language, asking the Department of Developmental Services to see what was going on with the autism population in our system. And that report, which by the way was done for free, there was no money that was appropriated for that report, came out and showed a 273% increase in autism. The next day, the Los Angeles Times had a front page story, California reports epidemic of autistic children. That was the report that really lit the match behind all the awareness about autism, not only here in California, but throughout the country and throughout the world. I'm very proud of that effort, and this request before you today is a follow-up, basically our next steps in following this population. And again, if DDS could do it for free, I think $500,000 is a little much for any other department to be asking for to do this work. Thank you.
Thank you. Next witness.
Madam Chair and members of the committee, I'm Patrick Pine, Administrator of the Robert F. Kennedy Medical Plan. My comments are in reference to proposal number 11. The Robert F. Kennedy Medical Plan ensures 13,000 lives, which includes farm workers and their family members. It is a self-administered plan with an employer contribution averaging $3 an hour and approximately $25 million in annual claims paid. Less than 5% of the entire budget goes to administrative costs. The plan has made all adjustments to ensure compliance with the Affordable Care Act. Last year, the legislature and the governor approved $3.2 million for the purchase of stop-loss insurance, which has protected the fund from insolvency. We were able to generate a net savings to the state of $400,000. With the farm workers' request this year of $2.5 million, and with applying the Department of Healthcare Services and the University of California's metrics, the net savings to the state's general fund is estimated to be $4.13 million. Thank you for your consideration.
Thank you very much. Next witness, please, 2 minutes.
Good evening. My name is Michelle Nevins, and I'm representing the California Association of Caregiver Resource Centers, item number 12. There are more than 6 million unpaid family caregivers in California, and we're simply looking to restore funding back to 2008 levels. In 2009, we sustained a 74% cut, one of the largest funding cuts in health and human services programs. And in case you weren't already aware, current statistics of our aging population have increased exponentially, yet we are trying to serve family caregivers back to levels that were basically from levels from 1987 when we first opened. Caregiving can happen to anyone, and family caregivers are the backbone of our long-term care system. The AARP Public Policy Institute estimates that caregivers are valued at providing $234 billion worth of support, and if Medicare and Medi-Cal were to cover that, it would be $889 billion. So as you can see, the $7.6 million investment is relatively small. I just encourage you to look at this and support our request. Thank you.
Thank you very much. Next witness, please, 2 minutes.
Thank you. My name is Dev Berger. I'm a former health policy consultant. I'm here today. I was a client of Del Oro Caregiver Resource System. My husband died from Parkinson's and Alzheimer's, so I am intimately aware of the necessary services that family caregivers need. We must have a consistent structure, because without a consistent structure, we can't provide the assessments and family services in a very constructive fashion. What are the other reasons? If we don't have a consistent structure, we're not able to align ourselves with the long-term initiatives that are going to impact family caregivers and already do. And of course, most importantly, we need that system in order to service families. While we know that family caregiving might be serviced by disease-specific organizations and maybe some other programs, the fact is they're not connecting the dots. And that means that we waste money, we waste time, and we don't have an effective system. Okay, we have 6 million unpaid family caregivers of uncompensated care. And statistics are showing that they are providing in California $8,000 of uncompensated care. Quite frankly, I think that's a low estimate. I left a well-paying job in order to care for my husband. By the time he passed away, I was looking into the eyes of bankruptcy. How much money are we spending on family caregivers in California? About $3 a piece. Can't even buy a coffee latte with that. I'm asking you to reinvest in family caregivers. We not only are a terrific investment, it is a compassionate thing to do. Thank you.
Thank you very much. 2 minutes, please. Next witness.
Hi, my name is Daniela Tena-Perez. I am from Ultimate Health Services, and we are an AFLP provider. We are definitely in support of the restoration of $7.8 million to this program. It is a very successful program. It reduces pregnancy rates. It increases high school graduation, improves parent and child health. It definitely is an investment and can, in the end, save money to the state.
Thank you.
Thank you.
Next witness.
Thank you, Madam Chair, Senator Monning. Peter Hansel with the California Association of PACE programs, the all-inclusive care for the elderly. This is on item 9, the geographic rate disparity. This proposal would address serious disparities across the counties that PACE operates in their rates. Many of you know, PACE is a comprehensive care provider. It receives a capitated rate. It provides services to keep frail seniors out of nursing homes. And PACE is basically at risk for the entire array of services that must be provided to keep these seniors in their communities. There's no flexibility to adjust services, withhold services of any kind in order to deal with any kind of funding challenges. So basically the problem is the rate setting for PACE is derived from fee-for-service Medi-Cal. So in the counties where the PACE programs operate, the funding base or the basis of the rates comes from the fee-for-service use of services. So, and as you know, in many counties there are significant access barriers, underutilization of services, and those problems essentially produce artificially low PACE rates for these capitated programs for these very frail seniors. It's a problem in 7 of the 12 counties at the moment that PACE operates, so it's a serious problem. It's not just a Southern California problem, it affects some other counties as well. So our proposal, it's before you, would set up a process for PACE organizations to request to have their rates readjusted using better data from benchmark counties where the underlying utilization is more reflective of the PACE model. It's not an automatic rate increase. It would be case by case, subject to review and based on the data. We think it's a reasonable proposal. We have discussed it with DHCS. It would go a long way to addressing fundamental inequities in the way the rates are set currently. So we'd ask for your prioritization of this. Thank you.
Thank you, sir. Next witness, 2 minutes, please.
Good evening, Madam Chair and Senator Monning, Michelle. I am Dr. Marie Torres with Ultimate Health Services in Los Angeles. As a federally qualified health center, we serve 185,000 patients in LA and Orange counties, including 1,700 PACE participants, and are successfully keeping these frail seniors at home through the comprehensive integrated healthcare model. The problem of rate disparity among PACE organizations has been outstanding and needs to be fixed. We have raised this issue with the department for many years, and no action has been taken to address this concern. Our actuaries did an analysis and found flaws in the underlying fee-for-service data used to set the rates. These flaws result in much lower rates for several counties, especially in Southern California. LA County has the lowest Medi-Cal rates of all the PACE organizations. This is a serious problem since 25% of our frail seniors are not eligible for Medicare, and the Medi-Cal payment is insufficient to pay for all the required services to keep them out of a nursing home. We want to work with the committee to secure rate disparity relief in order for more frail seniors to access this vitally needed program. Thank you so much for your attention tonight.
Thank you very much. Appreciate it. Ms. Aroner.
This is it, Senator Mitchell.
Under 2 minutes.
Yeah, I'm here on behalf of LA Jewish Home, which is one of the facilities in the PACE program that is affected by the rate disparity. And so we are looking for. I want to align my remarks with them. Okay. Excellent. But I'd also like to bring up, and also on behalf of the Center for Elders Independence in Alameda County, which actually is not in the situation with these, but as a PACE program, we support trying to figure out how we get rid of the disparities. Right. Then secondly, I didn't realize you weren't going to take any discussion on the rate issues on the last page of your agenda. So I would just like to, on behalf of LA Jewish Home also, we've submitted some language regarding the clawback because it means $5.5 million to LA Jewish Home, which would mean that the $10 million they raise every year just to keep their doors open, their operations part, would be cut in half, which means it would affect the DP SNF there, which provides needed services to aging people who have severe mental illness issues. So we hope you will consider rescinding the clawback language from AB 97.
Thank you. And again, we're not hearing those issues because they were previously heard. I didn't know that. That's okay.